Hello and good afternoon, dear students. Today we will discuss about hyperaldosteronism and Cone syndrome. In this video, we will discuss about the introduction, types, causes, diagnosis, and treatment plan of hyperaldosteronism. So, what is the introduction of hyperaldosteronism? Hyperaldosteronism, it is a condition in which we will see high level of aldosterone. So a condition in which we will see a high level of aldosterone, this condition is known as a hyperaldosteronism. Now we will discuss that there are how many types of hyperaldosteronism. So guys, if we discuss about the types of hyperaldosteronism, there are major two types of hyperaldosteronism. One is primary hyperaldosteronism. What is a primary hyperaldosteronism? And other one is a secondary hyperaldosteronism. Other one is a secondary hyperaldosteronism. In some books, there is also third type of hyperaldosteronism, which name as glucocorticoid hyperaldosteronism. What is a glucocorticoid hyperaldosteronism? But in USMLE step 2CK, only one type of hyperaldosteronism is discussed in full detail, but we will discuss all the types of hyperaldosteronism because all these types are very important regarding to your exam. So first of all, we will discuss about the primary hyperaldosteronism, and in detail, if we want to discuss about the primary hyperaldosteronism, first of all, we should know the normal physiology of aldosterone. Right. Aldosterone is basically produced from adrenal gland. In adrenal gland, there is a cortex layer. The name is a cortex layer. The cortex layer is further divided into three layers. Cortex layer is further divided into three layers. One is zona glomerulosa, one is fasciculata, and the third one is reticularis. Okay guys, so what is the main mechanism of action for the production of aldosterone? In adrenal cortex, from the zona glomerulosa, aldosterone is basically produced. So if someone asks you that in normal person from where aldosterone is basically produced, we can give the answer that aldosterone is basically produced from the zona glomerulosa, which is a layer into the adrenal cortex. And what basically regulates the aldosterone? This is very important question which is asked many time in the exam, many time in the exam. And this, I hope so everyone who's listening me must know about the RAS mechanism. Yes, in a RAS mechanism, guys, you know that in RAS mechanism basically there is produced the renin hormone. This renin is basically what the end product of the RAS mechanism. The end product is a angiotensin 2. This angiotensin 2 give the message to the zona glomerulosa, which is present into the adrenal cortex, to produce the aldosterone hormone. So if someone asks you that aldosterone is basically regulated by which of following, you have to give the answer. The best one is the angiotensin 2. Which one is the best one? Angiotensin 2. And why? Because RAS mechanism basically activate and produce the aldosterone hormone from zona glomerulosa in the adrenal cortex. So when the aldosterone hormone will produce, what it will do? The normal function of aldosterone is to bring the sodium from your collecting tubules into your blood. Okay, if this is a blood, it brings the 2 sodium molecule into the blood, and it basically take potassium and H plus from the blood and brings into the kidney tubules. When potassium and H plus are the proton will come into the kidney tubules, where it will go? It will go into the urine. And when sodium will go into the blood, it means that it can lead to the hypernatremia. Hypernatremia means high level of the sodium. And when the sodium will go into the blood, everyone knows that water always follows sodium. Where the sodium will go, water will also go at that side. So sodium is going from the kidney tubules into the blood. When sodium will go from the kidney tubules into the blood, it means that water will also go from the kidney tubules into the blood. When the water will go from the kidney tubules into the blood, it can lead to the hypervolemia. So we come toward the main topic, that what is a hyperaldosteronism or the Cone syndrome. As I have discussed that aldosterone is basically produced from adrenal gland zona glomerulosa. How many adrenal glands are present in our body? 2 adrenal glands. Just take an example. If there is a bilateral adrenal hyperplasia, adrenal cortical hyperplasia, because I said that adrenal zona glomerulosa is basically layer which present to the cortex. So if someone asks you a question that what are the causes of hyperaldosteronism, we will say that the causes of the hyperaldosteronism is this: if there is a bilateral adrenal hyperplasia, bilateral adrenal cortical adrenal hyperplasia, number 1. Okay guys, number 2, just take an example. If there is a tumor into the cortex or in the zona glomerulosa, so what we will see the high level of the aldosterone. So tumor into adrenal cortex. Okay guys, both these condition, what they will do, both condition will increase the production of aldosterone. So when both will increase the production of aldosterone, so where is the problem is basically into the gland. When there is a problem into the gland, so this type of the hyperaldosteronism, we will say this one is a primary hyperaldosteronism. So if someone asks you a question that what are the main causes of the primary hyperaldosteronism, what we will give the answer? Maybe there is a aldosterone secreting adenoma or the tumor. Number 1 cause, maybe there is a tumor present, number 1. Number 2, maybe there is a carcinoma, adrenal cortex carcinoma. Number 3, maybe hyperplasia, adrenal cortical hyperplasia, guys. So these are the causes which can lead to the primary hyperaldosteronism. So now we'll discuss that what we will see in a patient when there is a high level of aldosterone. Symptoms or how we can diagnose this patient. Guys, tell me that aldosterone basically bring the sodium from the kidney tubules into the blood. When sodium will come from the kidney tubules into the blood, it means that the water follow to the sodium. So water will also come where? Into the blood. So it can lead to the hypervolemia. Yes, hypervolemia, and it can lead to the hypertension. Number 1. Sodium will go into the blood. So when there is a high level of the sodium, it can lead to the hypernatremia, high level of the sodium into your blood. Number 1, we will say hypertension in a patient. Yes. Number 2, we will say high level of the sodium into the body of the patient. Number 3, what we will see? Guys, we know that this patient basically secrete the potassium and H+. When this patient will secrete the potassium and H+, where the potassium will go? Potassium and H+ will go into the urine. When potassium and H+ will go into the urine, it means that level of potassium and H+ will decrease into your body. So when H+ level will be the low into your body, it can lead to the alkalosis. Where the H+ will be the present, it means that site is a acidic condition. For example, we know that in hyperaldosteronism, H+ basically go into where? H+ mostly in most concentration, the H+ go into the urine. So the urine will be acidic, but the body will be alkalosis. So this condition is known as a metabolic alkalosis. We know that the third condition is known as a metabolic alkalosis. If someone asks you a question that why we see the metabolic alkalosis in the patient of the hyperaldosteronism, we will give the reason that because aldosterone basically secrete the H+, and this H+ will go into the urine, and in the body of the patient we will see the low level of the H+, and if there is a low level of the H+, this can lead to the metabolic alkalosis. Number 4, what we will see? Hypokalemia. Yes guys, hypokalemia will see, hypernatremia will see, and other than that, number 5, we will see the polyuria and polydipsia. This also you have to write, polyuria and polydipsia. Other than that, guys, this patient have the edema. If someone asks you a question that if a person have the primary hyperaldosteronism, you just guys have to remember that in primary hyperaldosteronism we have no edema. And if someone asks you that why you have no edema, we will say that due to aldosterone escape mechanism. What's basically is a aldosterone escape mechanism? Guys, we know that due to the high level of the aldosterone, sodium go into your blood. When sodium go into the blood, water follow the blood, so it can lead to the hypervolemia. When there is a high level of volume in our body, then it can lead to the production of ANP and BNP. When there will be the high production of ANP and BNP, these two hormones are those which basically cause the diuresis. diuresis. Because ANP and BNP, how these cause the diuresis? We know this is a glomerulus, guys. This is a afferent arteriole, this is a efferent arteriole. ANP, BNP basically act on the afferent arteriole and it causes the dilation. When afferent arteriole and efferent arteriole will be dilated, so maximum fluid where it will go? Toward the glomerulus, and it causes the constriction of the efferent arteriole, so fluid will come back toward the glomerulus. So it can lead to the increase the production or increase the glomerulus filtration rate. When glomerulus filtration rate will be increased, so all the fluid where it will go? It will go into the urine. Okay guys, so we will say that because of aldosterone escape mechanism, because of high production of the ANP and BNP, we will see the diuresis in a patient of a primary hyperaldosteronism. Okay guys, what we will see into the lab values of the primary hyperaldosteronism? In the lab value, first of all guys, tell me, if any patient present to us with primary hyperaldosteronism, we will see high level of aldosterone. Yes, when there is a high level of aldosterone, number one. Now we will see the blood pressure of the patient will be high. Yes, when the blood pressure of the patient will be the high, at that time RAS mechanism will be active or inhibit. In simple words, we will say that in any person, RAS mechanism only active in one condition, when there is a low blood pressure. When low blood pressure, then RAS mechanism active. Also the RAS mechanism active in sympathetic nervous system, or also RAS mechanism can be active when there is a low level of the sodium. But we know in this person we have the high blood pressure, in this person we have the high level of the sodium, so RAS mechanism will be inhibit. When the RAS mechanism will be inhibit, then what we will see? We will see the renin will be low. Aldosterone is a high, but the renin is a low. Okay, and if we take the ratio of aldosterone and renin ratio, aldosterone and renin ratio, it will be high, because aldosterone is the high in the blood, but renin level is a low. If someone asks you that what is the normal ratio, we will say it is more than 20. It is a more than 20, guys. If someone asks you that aldosterone control basically which ions, we will say it is a sodium and it is a potassium. Okay, we know that aldosterone basically main function is to bring the sodium into your body. Okay, into your body. Yes, in normal person, if we give the sodium, so the aldosterone production should be low. Yes, but in this condition, if you want to check the level, if we want to check that what happened to the aldosterone, we will give the sodium to the patient, but the level of aldosterone will not drop. In normal person, the aldosterone level is dropped. Yes, but in this condition, if there is a tumor into the adrenal gland, if there is a bilateral adrenal hyperplasia, if there is a cancer, adenoma, then we will say that aldosterone level will not decrease, it will increase. Okay guys, so upon giving a lot of sodium, aldosterone level will not decrease, it will increase in a person. I hope so everyone who is listening me must understand each and everything very clearly. So if examiner asks you a question like this, just take an example. I am giving you example that if examiner asks you a question that a 35-year-old male present to you with complaint of hypertension, number 2, headache. Due to low level of the potassium, it can lead to the muscle weakness. Upon lab investigation, okay guys, potassium level is just, the examiner said 2.5, which is very low. Okay, millimole per liter. Okay guys, number 2, the level of the sodium, the examiner say that level of the sodium is 150, okay, which is more, like this. And bicarbonate level, the examiner say that 30, which is high. Okay guys, so this condition is known as what's your diagnosis? So guys, tell me, for example, this person have the high level of high blood pressure, number 1, headache due to blood pressure, number 3, muscle weakness. When we come into the lab values, potassium level is a decrease, sodium level is a high, bicarbonate level is a high. Yes, if any patient present to us with hypernatremia, hypertension, low potassium level and high bicarbonate level, this condition is the hypokalemia. Yes, hypokalemia, hypertension, hypernatremia and metabolic alkalosis. So this condition is known as a cone syndrome of hyperaldosteronism. We will say this is a hyperaldosteronism. And if someone asks you a question that how we can diagnose the patient that this patient is of hyperaldosteronism, which test we will perform, we will say it is a aldosterone renin ratio. We will perform this test If this ratio is more than 20, we will say that the problem where into the adrenal gland, guys. Okay, now we will discuss about the secondary hyperaldosteronism. What is the secondary hyperaldosteronism? Okay guys, secondary hyperaldosteronism. Secondary hyperaldosteronism is not discussed in USMLE step 2CK. Now why I'm teaching here, guys? Because this is very important. This is the part of your medicine. It's not necessary that which thing is written only on the USMLE step 2CK you have to read just only that type of the material. Okay, I'm teaching you the things which are very important and not written on the USMLE step 2CK. I'm also teaching you that type of the material, and it will help you regarding to your exam. It doesn't matter that you are appearing USMLE, MCI, or also pleb or AMC, which type of the exam. It will help you, guys. Okay, first of all, that what is the causes of the secondary hyperaldosteronism? We will say it is a condition in which there is no problem into the adrenal gland. The problem is somewhere else. Yes, just take an example, guys. If there is a renal artery stenosis, first of all, I am writing the causes of secondary hyperaldosteronism. Number one is cause is a renal artery stenosis. Number two, congestive heart failure. I will discuss in detail all of them. Nephrotic syndrome. One is a nephrotic syndrome. Okay, guys. Number four, pregnancy. Number five, renin secreting tumor. Now I will discuss in detail that why renal artery stenosis can lead to the secondary hyperaldosteronism. Just take this is your kidney and this is a renal artery. Okay, if there is a renal artery stenosis, when it's a nerving, so your kidney will receive enough blood. Just tell me, guys, your kidney will receive enough blood. Your kidney will not receive enough amount of the blood. When your kidney will not receive enough amount of the blood, in this condition your RAS mechanism will be active. Yes, we know that on your distal convoluted tubules, this is a physiology and of RAS mechanism, that on the distal convoluted tubule there is presence of the juxtaglomerular apparatus. When on the juxtaglomerular apparatus there is a baroreceptor are present, which basically detect your blood pressure. When there is a low level of blood which will reach toward the distal convoluted tubules, so the baroreceptor will basically cause the activation of the renin hormone. And in this condition, what we are going to see? We are going to see renal artery stenosis. When there will be the renal artery stenosis, when the kidney will not receive enough amount of the blood, then the baroreceptor will secrete the renin. Okay, this renin basically will do the RAS mechanism will be the active, angiotensin 2 will be the produced, and it can lead to the high level of the aldosterone. Okay, renin is also high, aldosterone is also high. Okay, guys, so we will say because of problem into the renal artery, that's why aldosterone is producing in enough amount. So this condition is known as a secondary hyperaldosteronism. Now we will discuss about the congestive heart failure. Okay, guys, we know this is a kidney and this is your heart, and there is a problem into the heart. The heart is not pumping properly. When heart is not pumping properly, then the kidney will able to receive all amount of the blood? No, because kidney is not able to receive the blood because heart is not pumping. When the kidney will not receive the blood, then what is going to happen? RAS mechanism will be active. When RAS mechanism will be active, it can lead to the renin production. Renin will produce, angiotensin 2 will be produced, it produce the aldosterone, and in this condition when aldosterone will produce in a huge amount, it can lead to the hypertension, hypervolemia. Okay, guys, high level of the sodium. So in this condition also renin is a high and aldosterone is a high. Yes, guys, so the problem is not into the kidney or the adrenal gland. The problem is to the heart. Number third, now we are going to discuss about the cirrhosis. What happened into the cirrhosis patient, guys? In the cirrhosis, basically we know that liver produce basically protein, different types of the protein, and the best one protein is the albumin protein. What albumin do? If this is the blood vessel, the main function of the albumin to basically maintain the plasma oncotic pressure. What is a plasma oncotic pressure? Plasma oncotic pressure, it is a pressure which basically bring the fluid from the interstitial space into your blood vessel. Okay, guys, this is a cell, and into the interstitial space it will bring the fluid back into the blood vessel. Just take an example that if there is a cirrhosis, when there is a cirrhosis, then albumin is not going to produce. When albumin is not going to produce, then the fluid will not come from interstitial space into your blood vessel. When the fluid will not come from the interstitial space into your blood vessel, then what is going to happen? There is accumulation of the fluid into the interstitial space. When we will see the accumulation of the fluid into the interstitial space, it can lead to the edema. Okay, guys, it can lead ascites also into the cirrhosis patient, ascites, portal hypertension. These things can lead to the low fluid in this condition, the fluid will not reach properly toward the kidney, and it can lead to the RAS mechanism, because fluid is not coming into the blood vessel. Fluid is escaping from the blood vessel. When the fluid is escaping from the vessel, then blood is not properly reached toward the kidney. When the properly will not blood reach toward the kidney, so the RAS mechanism is going to active. Where the RAS mechanism active, angiotensin 2 is going to produce, aldosterone is going to produce, renin is a high, aldosterone is a high. Yes. Number 4, guys, nephrotic syndrome or the nephrotic syndrome. What happened into the nephrotic syndrome? We see the protein urea. When we see the protein urea, albumin is also protein. This protein will go into the urine. Plasma oncotic pressure will not be maintained. When plasma oncotic will not maintain, same mechanism, edema will be seen in a patient. When we see the edema, so the fluid will not be able to reach in the maximum amount to your kidney, so it can lead to the RAS mechanism activation. Number 3, pregnancy. Why we see in the pregnancy we see the high level of aldosterone? What is the main cause? We will say in pregnancy there is a high level of the estrogen. In simple words, estrogen, and high level of estrogen basically produce the renin hormone. Okay, guys, so this renin can lead to the RAS mechanism activation, aldosterone. Renin is also high and aldosterone is also high in this person. Last one, renin secreting tumor. If there is a tumor into the renin, okay, if there is a tumor into the renin, from where the renin is basically produced, we will say in the juxtaglomerular cells. Okay, in the juxtaglomerular cells, if there is a tumor into juxtaglomerular cells, then the renin will produce in a huge amount. When renin will produce in the huge amount, then the RAS mechanism will be active in a maximum amount. When RAS mechanism will be produced, then aldosterone will produce in a huge amount. So this can lead to the secondary hyperaldosteronism. Guys, what is the difference between the primary and secondary hyperaldosteronism? In simple words, this is the primary, this is the secondary. In primary hyperaldosteronism, the problem were only into the adrenal gland. Yes, adrenal gland problem. Number 1, maybe adrenal bilateral cortical hyperplasia, adenoma, or the carcinoma. These are the main causes. But in the secondary hyperaldosteronism, what are the causes? Maybe renal, not into the adrenal gland. The problem is somewhere else, into the kidney, into the heart failure, also cirrhosis, nephrotic syndrome, pregnancy, renal secreting tumor, like this. But how we can differentiate that this is due to the primary hyperaldosteronism or the secondary hyperaldosteronism? We will see not edema into the primary, but here we will see the edema, guys. Okay, number 1, we will see the edema. Number 2, how we can say the differentiate? In the primary hyperaldosteronism, we will see the aldosterone level will be the high, but renin level will be low. Yes, guys, but in secondary hyperaldosteronism, renin level will be high, also aldosterone level will be also high. So if we see, if examiner asks you a question that a patient present to you with complaint of the headache, hypertension, high level of the sodium, low level of the potassium, and metabolic alkalosis, and upon investigation there is a high level of the renin and high level of the aldosterone, this type of hyperaldosteronism is known as a, you have to give the answer, secondary hyperaldosteronism. Okay, guys, and if examiner asks you a question that a patient present to you with headache, hypertension, hypernatremia, hypokalemia, metabolic alkalosis, and other than that, upon the lab investigation there is a high level of the aldosterone, low level of the renin, this condition is known as the primary hyperaldosteronism. Okay, guys, there is also some other causes which can lead to the high level of the aldosterone. Ectopic ACTH, when there is a high level of the ACTH, guys, okay, this high level of the ACTH will not only produce the cortisol, this will also produce the aldosterone. So this is very important, you guys have to remember these things in your mind. Okay, now we will come to the treatment, that what is the treatment of the hyperaldosteronism, guys. So first of all, we have to know that where is the problem. Yes, so if someone asks you a question that in any person there is a high level of the aldosterone, which of following is the drug of choice? You have to give the answer, that is the spironolactone. Spironolactone is the drug of choice. Okay, guys, and examiner asked this question many times in the exam, that gynecomastia is side effect of which drugs? You have to give the answer, it is the spironolactone. Which one is the spironolactone? And other than that, we will say that spironolactone, it is a potassium sparing diuretics. What is mean by the potassium sparing diuretics? Guys, we know that aldosterone basically bring the sodium into your blood and secrete the potassium at H+. This drug, what it will do? This medicine, what it will do, the main function of this medicine basically to not bring back of the potassium from the blood to the kidney tubules. Yeah. And if someone asks you that what is the definitive treatment of the Cone syndrome of the primary hyperaldosteronism, we will say it is a surgery. Okay, guys. So this was all about the Cone syndrome of hyperaldosteronism. So I will discuss right now the most important points. First of all, if someone asks you that what is the hyperaldosteronism, we will say it is a high level of the aldosterone is known as a hyperaldosteronism. What are the causes? Two major causes. One is a primary, other one is a secondary. Tertiary is also, third one is also, but we do not have to focus more on the tertiary one. Primary and secondary, these are the more than enough. In the primary, the problem into the, we will say, adrenal gland, adrenal cortical hyperplasia, maybe, okay guys, maybe adrenal adenoma or the carcinoma. What we'll see into the lab values, aldosterone level will be high, very important, renin level will be low, okay guys. And other than that, what we'll see, high level of the sodium in your blood, low level of the potassium in your blood, low level of H plus in your blood can lead to the metabolic alkalosis, very important, hypernatremia, metabolic alkalosis, hypertension, all these things. And in the secondary hyperaldosteronism, what are the causes? Renal artery stenosis, heart failure, cirrhosis, nephrotic syndrome, pregnancy. These can lead to the high level of the renin in the body, also high level of the aldosterone. How we will treat? Potassium sparing diuretics, which is the spironolactone we will give in this patient. And what are the side effects of the spironolactone? High level of the potassium and also gynecomastia. Which one is the definitive treatment? We will say the definitive treatment is a surgery. And if someone asks you that the patient have the high level of potassium and gynecomastia, can we use any other drug? We will say yes. And in this condition, we will use the amiloride. Okay. So now I will teach you guys from USMLE step to CK the things which I already have explained in full detail here and not written on your USMLE step to CK. You guys can write your own self. Okay, just 1 minute, guys. From USMLE step to CK, just 1 minute. We will come here. Yes, there is only from here to there is written just like this, not more. Yeah. Just this one. Okay guys, result from excessive secretion of the aldosterone from zona glomerulosa, I have discussed this one. Adrenal cortex, yes, it is usually by bilateral adrenal cortical hyperplasia. This one also 60 to 70%, but can also result from the unilateral adrenal adenoma or carcinoma. Okay guys, present with hypertension, headache, polyuria. I also have discussed why there is a polyuria. Okay, because aldosterone escape mechanism, ANP and BNP will release, can lead to the polyuria, polydipsia, muscle weakness due to low level of the potassium because of the hypokalemia. Consider hyperaldosteronism in young adult who are diagnosed with hypertension without risk factor or the family history of the hypertension. Mean that if someone have the hypertension, okay, high level, and the person is a young, maybe 30-year-old, and the patient of the hypertension, and if we have found the cause, that what can be the cause in that person, we first of all we have to focus on the hyperaldosteronism, because hyperaldosteronism can lead to the hypertension in a young person. Lab test, what we'll see, hypokalemia I have discussed in detail, metabolic alkalosis, hypomagnesemia, hyperaldosteronism, high aldosterone to plasma renin activity. Okay, usually more than 30 written here, in some books there's written more than 20. Okay guys, imaging only CT scan MRI we will do to diagnose that is there is adrenal mass. Okay guys, adrenal mass we will do the, and adrenal venous sample, there is a high aldosterone. Yes, why there is a high aldosterone? Because there is a tumor into adrenal glands, so production of the aldosterone is a high, there is a high level of the aldosterone, low level of the renin. How will treat the patient? Adenoma, we will do the surgery. Yes, and bilateral adrenal hyperplasia, what we will do? Aldosterone receptor antagonist drugs. And what is the name of the drug? Spironolactone we will give the first. But what is the problem? Has few side effects. What are the side effects? Potassium level will be the high, and also gynecomastia. If there is a problem, then which type of the drug we will give? We will give the amiloride. Okay guys, so this is a drug. So this is only written this thing. There's no written about the secondary hyperaldosteronism. There's no written about the tertiary one, that the other cause of the hyperaldosteronism. I hope so everyone who is listening me must know right now everything about the hyperaldosteronism. If you have any type of the question, you guys can mail me on my email ID dr.zb776@gmail.com. Okay guys, take care, we'll see you in next lecture.